The title is COVID Testing, Understanding How to Pick the Right Test. And unfortunately, most of the time, I realize that most people don't have a choice. But there is coming a choice of home tests. Those are all antigen tests. So a big question that everybody has, what is an antigen test? What is a PCR test? And we came up with a number, Bill Adams, who's on the patient council, we came up with a number of questions that we thought everybody would like to know the answers to. And some of these things we have covered before, but I need to refresh your memory because of the importance of testing. So how the infection takes hold and how it spreads from person to person. How do you get disease, basically? Time and progression of disease, timing of testing. When are those who have disease most infectious? Just to refresh your memory on the symptoms of COVID-19, because when you're around people, if they have certain symptoms, you should probably avoid them. And if you get certain symptoms, there are certain ones that you would worry about and would encourage you to get tested. And then the difference, as I already alluded to, is difference between PCR, antigen, and antibody testing. And then how should you sample for infection? If you do want to get a test, what test is best under what circumstance? And I also want to present some data on the usefulness of monitoring your body temperature, testing for fever, and how that particular effort could actually complement testing and make testing more valuable to you and make it easier for you to actually know what's going on. And then I'm briefly going to review what we feel the ideal testing system should look like. So first of all, how does SARS-CoV-2 cause diseases? Well, in this case, here is a schematic image of the virus. And you see it's a little circle with a lot of little spikes. And it looks on electron microscopy a little bit like a crown. And so it got the name corona for crown virus based on its appearance on ultrastructure and electron micrographs. And those little spikes are actually proteins that bind to cell receptors. And the spike protein for SARS-CoV-2, the virus that causes COVID-19, binds specifically to a receptor on most cells called ACE2 receptors, including all the mucosal lining of your nose. As soon as it binds, within 10 minutes, it gets into the cell. And there it produces new viral RNA. So it actually can orchestrate production of its own RNA. And that RNA in turn orchestrates the production of proteins in the host cell. And meanwhile, it continues to replicate RNA and produce the protein. And then it forms a whole virus. And that virus then exits the cell. This whole process takes approximately 10 hours. And each individual cell can produce approximately 100 virions. So they're little viral factories, and they're continually producing virus, can produce 100 virions within 10 hours. So this is why we can get such massive numbers of virus in your nasopharyngeal passage. Now, when you first become exposed, as I've mentioned before, it mostly grows within the lining of the upper airway, the mucosal lining. And so for those first 24 to 48 hours, most people have no symptoms. And yet in that early pre-symptomatic period, there are large numbers of the virus coming out of the cells that are infected and populating the saliva, the sputum, and at about 48 hours, the virus, the little black particles, migrate down the bronchi into the different parts of the lung and end up in the alveoli. And the alveoli are little air sacs that are responsible for exchanging air into the arterioles. And if these alveoli become filled with fluid, which is what happens when the virus infects the alveoli, there's a tremendous amount of inflammation and flooding of the alveoli with inflammatory fluid. As a consequence, the lung can no longer exchange oxygen. Now, it's interesting, when they get down to this point, patients generally are less infectious than when they have the virus in the upper airway. Now, what are the symptoms that people present with when they become symptomatic? 4 things that I always like to ask about and any illness. And first of all, we would like to know now, did your friend or family member, did they do something that might increase their risk of being exposed to someone else that's carrying the virus? So that's the epidemiology. Did they go to a crowded environment? Did they eat in a restaurant? Did they go to a bar? Did they have some friend that's been sick recently with COVID-like symptoms? And then we like to know how rapidly the disease comes on. And it turns out that COVID-19 comes on, it's acute. It comes on in 2 or 3 days, at the slowest 5 to 6 days. And the key symptoms are fever, dry cough, and later on, shortness of breath. And we also like to know something about past history, specifically whether an individual has hypertension, diabetes, cardiovascular disease, or pulmonary disease, or cancer, because these individuals are going to get the vaccine earlier because they are at higher risk of hospitalization and serious complications, including death. Now, I've shown this before. This is the largest series from China that was published in the New England Journal. And it looks at all the symptoms and the frequency of those symptoms in individuals who are proven to have COVID-19. As you can see, fever here was defined as a temperature of 38 or 100.4. And the medium gray is all the patients. Light gray is those with mild disease. The black is those with severe disease. As you can see, 90% of individuals had fever in this series. About 70% had a cough. The majority were dry, but about 30% have some sputum production, so a little bit of fluid. And then the next symptom, shortness of breath, you can see overall it's only about 18 to 19%. Mild disease, it's about 15%. In severe disease, it's much higher. It's nearly 40%. So when someone is short of breath, that usually means they're developing severe disease. Severe disease means you need to be hospitalized. And then fatigue, muscle aches are other key symptoms that are relatively nonspecific, so they aren't very helpful. A moderate number of people complain of headache, nausea and vomiting, diarrhea and abdominal pain, and a very specific symptom, but present in about 10 to 15%, is loss of smell and taste. Now, fever. There's a large series, Cochrane series, which reviewed hundreds of multiple studies, and they found that they looked at many symptoms. Fever was the most sensitive. In other words, a high percent of patients with COVID-19 will have fever, approximately 80 to 90%. So it's a very helpful sign, and it should be present in most cases of COVID-19. The other very interesting study from the WHO, studying 55,000 patients, and found that in the majority of cases, the first symptom is fever. The second symptom that comes on is cough. Third, sore throat, headache, muscle aches. Fourth, nausea and vomiting. And finally, diarrhea. And I must say, in my experience, almost every patient that I have, if I ask carefully, the first symptom they note and the first thing that they do is check their temperature. They do first develop a fever. And then the problem is that 40 to 60% of individuals deny symptoms. So they are what we call asymptomatic infected. This is more common in children and adolescents. And this is what makes this disease so scary and why it spreads so rapidly, because individuals don't know they have the infection early on, and therefore they accidentally spread it to loved ones or friends, or go into an environment where they spread it to others. So now to turn to the laboratory testing, and there are 3 major forms of tests. First, the reverse transcriptase polymerase chain reaction. And what this is based on is, as soon as the virus was sequenced, that sequence was shared throughout the world within 7 days. And then everybody started to design little primers, little pieces of the RNA that would specifically bind to regions of the RNA virus. And those are called primers. Having these primers, they would stick to either side, and then you could allow them to grow back and forth when you heat and cool. And in this way, we're able to produce large amounts of, it's a reverse transcriptase, because the first step is to convert the RNA to DNA and then amplify the DNA. And so you heat, and that separates the chains. Then you cool, the primer goes on a new chain, and they produce another chain, and you keep producing chains. So each time you, it's called a cycle threshold, series of cycles until the DNA product is detected. If you have a lot of virus, then you'll have multiple templates within which to form the new material, and it will take fewer cycles to reach that threshold. So if you have a cycle time of only 15, that means you have a lot of virus. If you have fewer viral particles and less RNA, you will take more cycles to get to the threshold. And when you get threshold of 30, that means there's not as much virus. Now, this technique can detect 10 variants. It's very specific because these probes are very unique and they don't bind to anything else. It's considered 99.5% specific. And we'll talk about specificity and sensitivity a little later. It's not ideal, and as far as sensitivity, it's 70 to 80%. And that's because of sampling issues, which I'll talk about. Nasopharyngeal, for some reason, sometimes it sheds and sometimes it's not. Saliva is a little bit better, but it's not much. If people are infected, you only test as positive only 70 to 80% of the time. So the way that it started, we always did nasopharyngeal swabs, and they had to be way back in the nasopharynx. It feels like it's going into your brain when they do a deep sample. Now, actually, we do a mid-nasal sample. But more recently, Yale found that if you just spit saliva into a little jar, a small quantity of it, that actually carries the virus, and it can be left in that saliva and transported, and really is stable for several days. So this is much easier. And then you just take that saliva, you treat it with called proteinase K, which destroys the outer wall, the proteinaceous wall of the virus, and then you're able to do the PCR on that. And here just shows the percentage of positive, that is the sensitivity, and the green is the nasopharyngeal, it's about 70. You can see the saliva was a little bit more sensitive. It was at 80%. Here also the saliva is a little better. This is a very sensitive test. It takes 3 to 4 hours at least to produce enough of the DNA to detect it. So it takes time. It's also very expensive. It takes a lot of reagents. You have to have this special equipment, heating and cooling. It's technically tricky. You have to have good laboratory technicians. And I know at UF, John can tell you that that's predominantly what they're doing, PCR. Now, the SARS-CoV antigen test came out later, and this was released about a month and a half ago. And here you use an antibody that binds to, in most cases, the spike protein. And then by binding to that spike protein, you can then cluster the virus on a bar, and then you have a second detector, little silver beads that give a dark line when the virus is present. And the test is very much like a pregnancy test in that you have a control bar and then an experimental bar. And if that second bar lights up, and this time you're not pregnant, you have SARS-CoV-2. There are 3, and there's actually a 4th one has just been released, and there's actually a 5th one that's available for home. But the sensitivity of these are a little bit less than it can be a little bit less than a PCR, about 67%. But the specificity is quite good, 99.5, up to the highest is 77% sensitivity, but the Abbott is a little bit less specific. The good news is, because it's simply the binding of an antibody to an antigen to an antibody, this takes 15 minutes to develop. So this is a point of care test. It's not as sensitive. It will detect 120 to 150 virions. So it's a log less sensitive. This test is less expensive. It's very rapid. It's slightly less sensitive and a little bit less specific than PCR. And then the third test that you'll hear about is antibody tests. And anytime you're infected with a virus or a bacteria, your body generates antibodies. It detects this foreign invading pathogen and develops IgG and IgM. The problem is it takes 7 to 14 days for the body to begin to generate those antibodies. And here is quantity of antibody in the vertical axis. This is days from the onset of symptoms. And you can see 7 to 9, there's no immunoglobulins. And then finally at day 10 to 12, it begins to rise. And you'll notice this curve is low, this curve is higher. That's because this is a person who had mild disease. This patient had severe disease. So when you have severe disease, you generate higher levels of IgG and IgM. But they really significant quantities aren't seen for 14 days. So clearly this is not useful for making the diagnosis or for screening. It is really an epidemiologic tool to decide in one area how many people have had COVID-19 over in the last 3 months, 3 or 4 months. You can do a prevalence study to determine that. And so this is an epidemiologic tool. It's not really used for diagnosis. So to just summarize, the PCR molecular test detects viral RNA. It takes several hours. Situations, the results haven't returned for 7 to 10 days. It's best for diagnosis because it's very specific and for decisions to treat. The antigen test is a rapid turnaround. It's less expensive. It's what we call a point of care test, and it detects viral proteins. And this, because it's so quick, it is best for screening. And then the antibody test, which measures immunoglobulins directed against the viral proteins, is used strictly for epidemiologic studies. Apologize, there's no way to make this simple, but Bill and I tried to put it together. And if you feel free to ask questions at the end about this. There are 2 key characteristics of every test. Sensitivity. That is, if you have 100 people with documented SARS-CoV-2 positive viral culture, how many of those individuals will be detected by the test? If the sensitivity is 80%, then you're only detecting the virus in 80 of those individuals. If the sensitivity is 70%, then you're only detecting 70 of the true positives. What that means is that you're going to have a certain percentage of cases that are going to have a negative test when in reality they have the infection. And that's called a false negative test. Obviously, the higher sensitivity is preferred. The higher the sensitivity, the lower the percent of false negative tests. And then specificity, how specific, how accurate is this test in detecting the virus? When we do this, we think about this test. If we take a group of individuals we know are culture negative and are not infected, how many will be test positive? That would mean a false positive. If we test 100 individuals who are SARS-CoV-2 culture negative, what percent will be detected as positive by the antigen test? An individual who is culture negative and antigen test positive is defined as a false positive test. In other words, it appears the test says they have the virus when in reality they do not. The higher the specificity is clearly preferred, and the higher specificity, the lower the percentage of false positive tests. It's important to know the course of viral concentrations within the saliva and sputum in relationship to symptoms and exposure. 3 to 5 days following exposure, the virus generally becomes detectable. High concentrations of virus are found as patients become symptomatic. Generally, the virus cannot be cultured after 10 days. And when they're shedding beyond that, it's just dead viral particles that are releasing RNA. So here is a graph showing what happens. You become exposed at week 2. Right here is the exposure. And then after 3 to 4 days, this red line is the virus viral culture. You can see that it goes up. Also, the antigen test actually, because it's measuring the proteins of the virus, also follows this curve. PCR is more sensitive and it can detect small quantities of the virus and will usually turn positive or a little bit earlier than an antigen test. And it goes very high, but at day 10, the culture is negative, but the PCR persists and can persist for weeks. This is a result of RNA that's being released from dead virus that persists in the body. And then finally, as we mentioned at day 10 or 11, about the time the virus disappears from culture, the IgG begins to be produced and the IgM begins to be produced. And the IgG will persist for months to years. The IgM usually go down in about 1 to 2 months. So a positive IgM means a recent infection. A positive IgG could be recent or later. But you can see that this clearly will not detect virus when the individual is infectious. If you test, this is what happens quite frequently. A person gets exposed, they're very upset. They want to make sure they didn't get infected. So after 1 to 2 days after exposure, they go and get a test. Well, we know that it takes 3 to 5 days before the virus is detectable by PCR or antigen. So if you do it too early, you get a false negative test. Then the other key characteristic of this virus is how many people it infects. And when the infection is full blown, you have one individual will infect average of 2 to 2.7 individuals. About 40 to 60% of the people that are infected will be asymptomatic, and the others will have symptoms. Again, the most infectious period is right in here. The first 2 or 3 days of symptoms, the virus is highest, and then it goes by day 10 of symptoms, you're no longer infectious, although the PCR will continue to shed RNA. So what is the likelihood you have SARS-CoV-2 if you have no symptoms, but you're worried that you might have come in contact, and you wait 3 to 4 days? Well, it depends on the prevalence of infection in your area. In Florida, actually, it's now up to I think it's almost 11% of all tests being performed in Florida, PCR antigen, are positive. That means the pretest probability of you having the virus is 8 to 10%. Well, it turns out if that's the pretest probability, if you get a positive test, it's likely to be a true positive. And if you have a negative test, it's likely to be true positive, true negative. However, if you're early on in the epidemic, when we had 2%, or if you're lucky enough to live in Maine right now, the prevalence is only 2%. In other words, if you have 100 tests, only 2% of those 2 are positive. Now, what that means is if you get a positive in this where there's this low pretest probability, about 20% of the time, even with PCR, it could be a false positive. A negative would be a true negative. I want to introduce you to one more sort of concept, and that is the idea that if fever is present, most patients, including asymptomatic patients who are infected with SARS-CoV-2, should have a fever. This is my prediction, and this is based on my understanding of how this disease causes inflammation, the virus. It turns out when the virus binds to the surface of cells, it stimulates these toll-like receptors, which are warning signals saying there's a foreign virus trying to get in. And also when this foreign RNA comes in, there is actually stimulation of other toll-like receptors, also warning of something foreign in the cell. And these in turn set off a signal cascade that produces what we call cytokines, and TNF, IL-1 beta, and IL-6 are predominant. These cytokines cause the body to they raise the body's core temperature, and individuals develop fever. There's every reason to believe that when there are 100 viral particles within a cell, that there should be cytokine production and fever production. Should a rise in body temperature be used as a pre-screen prior to ordering PCR or antigen testing. And individuals should take our oral temperature 1 to 2 times every day to establish a basal core temperature and to identify the early and could identify the early onset of disease. Remember, fever is the first symptom and sign. I've actually been experimenting this for quite a long time, and I'm using this electronic thermometer that interacts through Bluetooth with my smartphone and records keeps a record of my temperatures. And you can see that my basal temperature roughly averages 97.5. If we say a fever is 100.4 or a rise from basal of 1.8 degrees Fahrenheit, then if I have a temperature of 99.3, that is my fever. See, each individual has a different basal temperature, and by using a strict cutoff, you actually underestimate by about 30% the number of individuals that have fever. So if you use a cutoff of 1.8 degrees rise or 1 degree of Fahrenheit or 1 degree centigrade as your definition of fever, you can do that if you measure your temperature daily for 3 days. We were lucky enough, KINSA gave us the temperature data, monitoring data for 500 individuals, all of who had tested positive for COVID-19. And we looked at the temperatures and how frequently they had monitored their temperature. And we found that overall, was 450 that actually fell into the age groups we were interested in, which was age 2 to over 80. 60% of the time was positive. If that individual had only checked their temperature once, the positivity rate was only 33%, the detected fever. So when you do a thermal measurement at the door, you only have a 30% chance of detecting COVID. That's not helpful. However, if you monitor for 3 days, the percentage of individuals that have detect a fever is 71.5%. That's the same sensitivity as PCR and antigen testing. It's not specific, but it does tell you that in the setting of a COVID outbreak, it's highly likely that you have SARS-CoV-2 or COVID-19. And what we also found that in this series, 33.8% had no symptoms. What about asymptomatics and fever? What turned out, if they check their temperature anyway, about 50% have a fever. However, if you monitor for 72 hours or greater, even asymptomatics, 65.3% have fever. And if you recall, one of the antigen tests had a sensitivity of 65.3. I would maintain that by monitoring your own temperature, you can actually detect the onset of this disease. And if you don't have fever, you can feel quite secure that you don't have COVID-19, and you don't have to wait in line for hours and hours to decide whether you're infected. What would be the likelihood of you having SARS-CoV-2 if you have no symptoms, but you detect a fever? This would give you a pretest probability now in going from 8% to 50%. And if you plug that into the pretest probability and you have a sensitivity of 75% and a specificity of 95%, if you have a positive test, it's 99.9% a true positive. A negative, however, it could be up to 20% a false negative. But you can see that by monitoring before you get the test, if you have fever, then if you get a positive test, either antigen or a PCR, it will be a true positive. So just to summarize, antibody testing is used for epidemiology and prevalence studies, and possibly with the vaccine to test immunity. RT-PCR is it should be used for a diagnosis and deciding on treatment because it is expensive, slow, and also detects non-infectious as well as infectious patients. You need to test by saliva or nasal swab. By the way, the antibody test is a blood test. You're getting the antibodies from your blood. The antigen test also needs a nasal swab. It is fast. It takes 15 minutes, nearly comparable sensitivity and specificity to PCR. And it's the preferred test for screening because of the rapid turnaround. And once the virus is died out, it will not be positive the way PCR is. How to interpret a test depends on what you predict the pretest probability of you having the disease is. If there's a high pretest probability, a positive test will be a true positive, but a negative test could be a false negative. And if you have a low pretest probability, a positive result could be a false positive, and a negative would be a true negative. And then I hope I've convinced you that a daily oral temperature for fever is of high value, particularly if you monitor for over 72 hours. It is the sensitivity of a rapid antigen test, and really can be thought of as the poor man's COVID-19 antigen test for home. And fever can be used to decide whether or not to go to get a test. And fever will increase the pretest probability to over 50%. And therefore, a positive would be a true positive. Now, finally, I created this mnemonic, tested. First of all, a testing system has to be timely. And in Gainesville, for hardly anybody waited over an hour for tests. And the turnaround should be less than 12 hours so you can act on it. Now, we had 12 to 24 hours for most people reported. There were some 48, 72, but we did not hear of any that were 7 and 14 days. Down in South Florida, there were. Equitable, we could not assess. By that, I mean, tests should be given to the frontline workers that are most exposed, not those that are sitting at home working, and to be healthcare providers and the most vulnerable, those with chronic underlying diseases. They deserve to be tested first. Yeah. And then S is for sensitivity and specificity. And we've talked about the importance of those two characteristics of every test. And T for transportation. Did you have to travel a long way to get that test? And it turned out in Gainesville, for the most part, you didn't. A few people had to go 20 to 25 miles, but that was rare. And then E is for economical and of high value. We found that most people, the insurance paid for it, but that's economical for you, but not necessarily for society. And I would maintain if you used the two-tiered approach with temperature before you do the antigen or PCR, then your test would be much higher value and would be more likely to be positive. And then finally, if you have a positive test, are there sufficient individuals to do in the health department to do contact tracing to make sure who you came in contact with, investigate that, and then make sure of all these individuals quarantine and stay away from others so the virus doesn't spread. So with that, I want to end and we can entertain questions. Thank you. So John, do you want to do the honors?
Sure. I don't see any questions in chat, but I do have a question of my own about UF's testing. So UF students have really impressive access to testing, but I was wondering if we know how effective these large systems are where there's just impressive access to testing, does easy access reduce viral spread?
In general, the more you test, the more you're going to detect these asymptomatic carriers, and the less likely you are to have inadvertent spread. The problem we get into is it worth testing people that only have a 3% pretest probability? I think it's a waste of money. Now, one of the problems is, that each PCR test costs about $100. So you can imagine how much money is being thrown down the toilet for these tests that are negative. We did yesterday, I think we did 10,000 PCR tests at $100 each. Wouldn't that money be better spent on new classrooms for our schools, improving the ventilation, and maybe paying for masks? I think this strategy is of low value. And this study that I just mentioned is in review in the New England Journal. So I'm hoping it'll get out and that people will change their present tactic, because I think it's a very expensive. It does work, but the problem is, depending on the prevalence of disease, you're going to have to test. The student is not mobile and hasn't gone to bars and things. You could probably test them every 2 weeks. But if they're doing social events, then you probably have to test them every week. So it really depends on, and then you could keep them out. Now it's very interesting. The White House, that was the White House's strategy. We're going to test everybody. We're not using masks. We're not going to worry about social distancing. How did that work out? I think there are now 100 individuals that are associated with the White House that have been positive. So that's a terrible strategy. And what we're realizing that testing alone will not control the epidemic, that you can't depend on that alone. What you need to do is, it's really a Swiss cheese model. You have to have multiple slices of cheese where the holes don't line up. So yes, test. Yes, you wear masks. Yes, socially distance. Yes, avoid crowds. Yes, avoid small confined spaces that are poorly ventilated. Don't stay in those for very long. And unfortunately, I wish I could say differently. You shouldn't go to restaurants and you shouldn't go to bars. And in-person religious ceremonies are exceedingly dangerous. So if you combine all those things, we would virtually have no spread whatsoever.